We're in studio with Dr. Kireki Omanwa. He is the president for the Obstetrical and Gynaecological Society of Kenya. And we'll be discussing, as we've said, fertility, fibroids, and breastfeeding. This is just a tap into reproductive health, and I think this should be an ongoing conversation. But we'll talk about, yes, what we struggle with as a nation, which is often information, right? It's getting that information out there. It's what are fertility issues? How do we destigmatize them? What are fibroids? You keep hearing, you know, what's the difference between a painful cramp and a fibroid? When should I go see a doctor? Breastfeeding, is it automatic that, you know, a baby comes out and there's milk? No. But is that what society often thinks? Yes. But karibu sana, Dr. Kireki.
Asante sana.
It's good to have you. Before we get into anything, Jano has a quote. She'll give you the quote of the day. You can tell us what it speaks to you, how you interpret it. Yeah.
Absolutely. On this very day, that was July 24th, 10 years ago, 2015, the then president of the US, Barack Obama, became the first sitting US president to visit the country. So on this day, 10 years ago, he arrived in the country. A few days later, just before he left, he made a public address at Kasarani. And one of the things he says is, progress requires that we honestly confront the dark corners of our past and extend rights and opportunities to more of our citizens. You agree with that?
Totally agree with President, His Excellency President Barack Obama, who was Kenyan, as they say. And what he quoted, that quote is very important, that we must address our dark past. We must address issues which have brought a lot of pain, have brought a lot of iniquities to ourselves and to the country at large. And these iniquities are actually across the board. May it be political, may it be health. And here, talking about health, there are iniquities everywhere. There are things which you were able to do in the past which you are not able to do. And now we are in a space whereby these iniquities are even more glaring. So I think it is important, and I totally agree with His Excellency Barack Obama, that in order for us to make progress, we have to look at these ghosts of the past and bring them to bed, and then from there we can make some progress. That's really good. And I think Mariam said the same thing earlier. If we don't address those injustices, then we'll continue building on them. As we get into our conversation, part of what kind of inspired us to have this conversation. This is to do with a powerful statement, a post that actress Lupita Nyong'o put on her Instagram. And she said that in 2014, she was diagnosed with chronic uterine fibroids and had 30 fibroids removed. She shared her experiences. She said this disproportionately affects Black women and called attention to the lack of treatment options and research. Now that post spread like wildfire, and I think a lot of people felt seen and heard. But it begs the question as to why these topics still remain so taboo in Kenya. And I think Mariam was saying that people don't know. It's a painful period, a fibroid, is it not? So maybe just very briefly is just to give a definition, an overview of fibroids, how different they are, and then just speaking to why these matters to do with women's bodies are still so taboo. Thank you very much. I think this is a very important topic. From the view of ladies, we take care of ladies, and generally what we call fibroids or fibroids, depending on where you went to school, or myomas as well. That is also another name. There is also call them leiomyomas as well, or leiomyomata. So there are different names to actually describe this growth. It is a growth which is non-cancerous, and we call it in medical jargon benign. It's a benign growth of the uterus. Now, depending on where it is, the location actually describes what it is. There are fibroids which we call submucosal, meaning they're just below the inner lining of the womb, the endometrium. So they sort of push the lining into the cavity. And the cavity is where a baby actually grows. They are intramural, meaning in the wall of the uterus. There are others which are pedunculated, meaning they are dangling. They are dangling. They can dangle from outside the womb, or they can dangle from inside the womb. They have what is called a stalk, and these they can dangle all the way to the cervix, and sometimes can be mistaken for cervical cancer as well. And then we have what we call subserosal fibroids, and these ones grow just under the surface, under the covering of the uterus. Then you also have others which are rare, where we call parasitic fibroids, cervical fibroids, and so on. It is a big problem, and it affects disproportionately women of African origin, whether it is Kenyan women, whether it is, where women of African origin, wherever they are, they are unproportionally bear this problem. It generally affects about anywhere between 30 to 60, even 70% of women of African origin in their reproductive period. It's a shock, isn't it?
You said 50 to 70?
Anywhere between 30 to 70%. 30 to 70%. It's a huge number. We actually don't know exactly what the cause of these fibroids are and why women of African origin are disproportionately, affected. Apart from the women of African origin being disproportionately, affected, the other thing is that the fibroids that our women have, number one, they are bigger. And number two, the numbers of those fibroids are also quite a bit. You read about Lupita Nyong'o, and she had 30 fibroids. I have removed 80 fibroids from a patient. My colleague, Dr. Odawa, wrote a paper one time, and it had a very enigmatic title, and he said, mine are 140. What are yours? He had removed 140 fibroids. Even though when I met him, he said somebody had surpassed his record, and he had removed 144 fibroids. So out there, when you work out there, I trained in Poland and in the UK, we never saw such huge numbers. And also the sizes of those fibroids are also huge. It is recorded that one of the biggest fibroids that has been removed is about 40 kilos. The biggest I've removed is 8 kilos. So you can use it as a weight reduction measure. 8 kilos.
That's like twins.
That's like twins, actually. That's like twins. Wow. So it is a challenge. And actually sometimes you find that these women may even not know that they're having fibroids because they are asymptomatic. The women who have symptoms are about 30 to 35%. And some of the symptoms of fibroids, number one, of course, is heavy periods. So when a patient comes, one of the first questions that we ask is about periods. How are your periods? When was the first period? Are your periods regular? How are your periods? Are they heavy? Are they light? Are there clots? And so on. And one of the first red flags is that my periods are very heavy. What do you mean by very heavy? Well, I use many pads. Which ones? We know as gynecologists, we know the types of pads that women use, maxi pads. So when a lady tells you that she uses maxi pads and she uses 3, 4, 5 of them in a day, and sometimes she has to use something extra, a napkin, and sometimes she uses a tampon and a pad, and there's still a leakage, that is a problem. For some women, they actually don't even go to work when they're having their period. So that is a big red flag. The next one is whether they are clots. Women say, yes, they are clots. Sometimes they are big. When I go to the loo, for example, for a short call, then I feel something, plumping into the basin. That is another red flag. The other one is that when I'm having my periods, I sort of I'm weak, I'm lethargic, I don't want to work. Sometimes I feel dizzy, and so on. That is also another red flag. Now, when we have finished with this information, we'd like to examine the patient and what we call palpation. So we ask the patient to lie on the couch, and we palpate the abdomen. And most of the time, even just by watching, you can see there is a problem because you find the abdomen is swollen. And when you put your hands there, you can actually feel these structures. It can be one, there can be several of them. The uterus we normally equate the size of the uterus to the size of pregnancy. So you can say the uterine size is about, let's say, 24 weeks of pregnancy, meaning it is above the umbilicus. Is it hard? Is it mobile? And so on. So that is also another red flag. And then the other thing, what we want to do a vaginal examination, because apart from feeling the abdominal, fibroids, there could be some other fibroids which are behind the uterus and which we can only discern by doing a vaginal examination. So we take that into consideration as well. We do radiology tests, that is pelvic examination, ultrasound, and that now will give us a lot more information. So basically, by taking the history, doing an abdominal and vaginal examination, most of the time, 70 to 80% of the chance we know that these are fibroids. We sort of have an idea where they are. So the next question is just to confirm our suspicion, and then of course map a way forward on how to help these patients.
That the statistics are shocking every time you hear them, and I know that they disproportionately affect Black women, but to this extent is really intense. Let me just begin with, a lot of the things you're saying could be confused as just a regular period.
Correct.
So, it could be, I'm lethargic, I'm tired. Clots, how big a clot should I worry about? Should periods be painful again? Let's start with there. What level of pain is normal, if any?
Actually, technically, the periods should not be painful. Or if they are painful, then when a patient takes a tablet of paracetamol, a tablet of ibuprofen, she should be fine. But when the periods are so painful, such that they affect her quality of life, then there is a problem. Then we are thinking about other things. Apart from fibroids, we'll be thinking about either adenomyosis, we'll be thinking about endometriosis, and other issues. So when a patient comes and says, I'm having heavy periods, heavy painful periods, we need to find out, ask a little bit more, dig a little bit deeper, and ask, when does the pain start? Does it end? When does it end? For patients who have adenomyosis or who have endometriosis, this pain normally starts a few days to even up to a week before the period starts. It reaches a crescendo when the period starts. So a day or two after the period has started, that pain reaches the peak, and then it starts dissipating slowly, and then it is periodical. Unlike the other pains, for example, if a patient has cramps because of fibroids, because they can have cramps, and the cramps basically is because the blood is accumulated in the uterus, and the uterus, quote-unquote, senses that there is something that is not okay, something that is growing here, and so it contracts to push out the clots. So that's where the cramps come from, amongst other reasons.
Yeah, I'm glad because I was actually going to ask about endometriosis and kind of how to tell the difference. And in just a moment, we'll transition to fertility, because I think there is also a link, and you let us know, Dr. Ari, between fibroids and fertility issues.
Absolutely.
But just very briefly, describing the slight differences between endometriosis and fibroids.
Now, endometriosis, when you talk about endometriosis, is one of the enigmatic diseases as well that we have. We also don't know exactly what we call the pathophysiology, meaning how is it that the lining of the womb, which is what comes out, the shedding. When a woman has a period, it is that lining which was ready to accept a baby, but there is no baby, so it has to come out. Now, this lining of the womb, which is active, is found in other areas of the body. It can be found on the tubes, on the fallopian tubes, on the ovaries, sometimes on the intestines, on the post-caesarean section scar, in the vagina, and so on. There have been very interesting cases of endometriosis, whereby endometriosis has been found in the joints. I've had a patient or two who've had endometriosis of the shoulder, endometriosis of the hip, lung collapse because of endometriosis. A colleague of ours had a very interesting case of a young lady who was, I think, 17, 18 years. When she started her periods, in the beginning, of course, they were very painful, but then she started bleeding from her joints, from her palms, and from her ears as well. One of our professors actually, wrote an article that he had a patient who had endometriosis from her fingers. How it gets there, we really don't understand.
That one's Jawaiskia. Let me tell you, as somebody who actually has endometriosis, I did not know that it's not limited to the reproductive uterus functions. Yeah. But also,
yes,
I don't know whether this is a political question to ask. Is it rare for many, the root of certain diseases or whatever it is, to be unknown? Because I think sometimes women may feel unseen and unheard because for several decades they've heard, we don't know the root cause, we don't know what this is. Is that widespread, or do you feel like it's something that's specific to reproductive health and rights, especially for women, or reproductive functions of women?
I think it's generally across diseases, across the board. It's not limited to reproductive health and to women, because there are some things that we see and we say we cannot put a finger onto the cause. What has really caused this? For example, when you talk about endometriosis, well, we know the symptoms and the effects of endometriosis, but how does that lining, that bit of lining, which is active and hormonally, how does it end up in the ears? How does it end up in the shoulder, in the lungs? How does it end up there? There are theories which are supposed to explain that, but when you think about these theories, they also don't explain a lot. So what we end up doing is we want to manage the symptoms. We want to make that patient as comfortable as possible and hopefully eradicate it to some point, if it is possible, and then move on. Because when you start now splitting the hairs, we say, okay, yeah, but it's supposed to go this way and that way, but we really don't get the nitty-gritty of actually answering that this is actually the method that this lining used to get to the shoulder, to the hips, to the lungs, for example, and so on.
Lungs I've heard, but I've never heard of the palms and fingers.
And fingers. I'm wondering if up to 70% of African women may have fibroids, right?
Correct. During the reproductive years. Then only 30 to 35 are showing symptoms. Then that brings one, what is the course of treatment, and is it necessary to treat if it's asymptomatic? Now, that is a very interesting aspect that you brought out. As they say, if it's not broken, don't fix it. Because the patients come and we ask, do you have any symptoms? Did you know that you have fibroids? He said, no, I don't know. I didn't know that I have fibroids. Because then we ask about the periods are heavy and whatever, and then we ask for what we call pressure symptoms. When she goes to for a short call, sometimes she feels pressed, and when she goes for a short call, you find that whatever comes out is not commensurate to the pressure she was feeling. And then after finishing, a few minutes, she still wants to go back. So that fibroid is pressing, or fibroids are pressing on the bladder. The same way with the long call. So you find she feels she wants to go. When she goes, whatever comes out in the long call is not commensurate to the pressure. So that is a symptom as well. There are others who have fibroids. They have 6, 7, 8 centimeters. They have no fibroids. they have no symptoms at all. Do they affect, the sex life? He says, no, they don't affect my life at all. My sex life, everything is okay. So if she has no symptoms, the general rule is don't operate, because it's not affecting the quality of life. But if the symptoms are there, then definitely we have to suggest ways of management. And there are several ways of management, beginning from what we call conservative management, up to surgical management and non-invasive methods of management. In the conservative management, we normally propose these to patients who don't want to go to theater for whatever reason, and it's acceptable, because sometimes we feel going to theater, will I wake up from that anesthesia? What is going to happen? Can I have complications? etc. So we offer them medications. There are different types of medications. Some can just be to relieve the pain symptoms. Some is to stop the periods completely. Combined oral contraceptive pills, for example. We can use a coil which is embedded with a hormone. We can use an injection which will stop the cycle completely. The only problem with the injection is that it will put the woman in chemical menopause and the attendant, symptoms, hot flashes, insomnia, mood swings, vaginal dryness, and so on and so forth. So when we tell this to the patient, said, I don't want to go that way because I already have a problem. I don't want to go into another problem. Yes.
And, sorry, go ahead. Yeah.
And then there are, and then of course, because course, we need to boost their blood levels as well, because they lose a lot of blood during their periods. We also need to give them what we call hematinics. Now, when it comes to surgical options, there are quite a number actually. And the first one is what we call laparotomy, where we cut the abdomen and we remove the fibroids one by one. Basically, any obstetrician and gynecologist should be able to do this, because this is what we are trained to do. The next option is what we call laparoscopy, where we minimally invasive surgery, where we operate using, you know, a few
like
small
lasers,
holes, small holes on the abdomen, and we go in with a camera, we use instruments, and we remove the fibroids and, you know, correct or suture where we have removed them. A very technical skill. It needs skill and it needs training. Not all of us are able to do that. And again, now with that will come with the inequity, availability, affordability, and accessibility of these health services. There is what we call uterine artery embolization, whereby we work with other colleagues, specialists, who are called interventional radiologists. They will put a small pipe through one of the vessels in the thigh, and it goes to the what you call the uterine arteries, and they block them. So when they block them, there's no blood supply to the fibroids, so they start shrinking. And of course, there is an issue of cost, and again, availability, affordability, accessibility. There is what we call hysteroscopic myomectomy. Tomy is basically to remove something. So in this case, this is usually preserved for fibroids which are called submucosal fibroids. So we go with a tiny camera through the cervix. If we imagine the womb as a balloon, and where we blow in the air, that is what we call the cervix, the neck of the womb. So we go in through the cervix with a camera and a tiny instrument, and we go and and slice off the fibroid or fibroids which is there or which are there. And then the last one is non-invasive. It's a new method which is available in Kenya. And by the way, this is a method which is available, I think, in 4 or 5 countries in the whole of Africa, what we call HIFU, high intensity frequency ultrasound, where the patient is not taken to theater. We don't need an anesthesia. We don't need blood, because when you go to theater, these patients where we're doing myomectomy, we must have blood, on standby. But here we don't have that. So that method is also available. So Lupita Nyong'o could have come to Kenya, her home place, and she could have had
She had just won an Oscar. She was busy. She won the Oscar and said shortly after, went for surgery, which nobody really knew. We're going into a break.
And just before we go on to the break, Doc, just before, and because we have so much to cover, and I think we'll have to do part 2s. The prescribing of birth control for period pain. Has it been overdone? Is there a danger there that it's become, especially for very young women, who, even in their teens? Is that a problem? Is that something? Just walk me through it.
Yes, when we think about period pain, as I said, periods should not be painful. And if they're painful, then we need to find out what the issue is. And once we found out what the issue is, then what options of management do we have? We are a bit cautious when we start talking about combined oral contraceptive pills in teenagers. Number one, they have not finished their growth. And usually they finish their growth around 18 years and so on. So if a patient who is 14, 15, starts her periods, usually they may be painful in the beginning, but they settle down. But if they continue to be painful, then we have to consider several things. Number one, the intensity of the periods, the heaviness of the periods, the periodicity of the period, and so on and so forth. Now, we don't dive into combined oral contraceptive pills straight away, because if we were to do that, we may actually stop the growth of these young girls. So we don't do that. We need to explore other options first. There are many painkillers which we can give. There are other adjunctive medications which you can give for these pains. So that one, we are very cautious about it. When it comes to mature women, it's a different story altogether, because the combined oral contraceptive pills, what they basically do is they stop the ovaries from working for a certain period of time. So long as a woman is taking either the combined oral contraceptive pills or a patch, etc., the periods can be stopped. Because remember, endometriosis thrives on estrogen, which is produced by the ovaries.
We have to go into so much information to glean in a short amount of time. The number to call us is 0719-038-858. You can call in and ask. We're already seeing some feedback. When we come back, we also talk about fertility and what some of these factors have. What role is there in fibroids, uterine fibroids, and fertility issues? And then towards the end, we'll touch on breastfeeding as well. We're coming back in just a moment. It is 7:30. Still, Mike the One says, fibroids patients, even on the days when the pain feels like too much or your energy is low, please remember your value doesn't change. You're still whole, beautiful, and deeply loved.
That's wonderful.
That's very nice, because a lot of people feel isolated in their experience. I mean, it affects work, it affects relationships, so it's important to have that support. Odero Kefa asks, are there certain age groups or lifestyles that are more at risk of developing fibroids? Can fibroids shrink or go away without treatment? Daktari will speak to that. He has, but he'll answer it in just a moment. Peter Ocheno says, knowledge is power. This information is also of value to men. I have learned so much in just a few minutes. You can also call us 0719-038-858. We hope we can get through as much as possible in a short amount of time. Maybe speaking to what that question was on lifestyles.
Yeah, lifestyles.
Yes,
and
age groups.
Can they shrink or go away on their own?
Let me start with the age groups. Yes, they do shrink with time, especially when a woman gets to the menopause. Once you get the menopause, the ovaries are not producing enough estrogen, and what studies have shown is that when the fibroids are taken and they were analyzed under a microscope and they looked for what we call receptors, and they found that there were more estrogen receptors than progesterone. Estrogen is the hormone which is produced principally by the ovaries, and it is what makes women women. You have a nice smooth skin, you have, you know, bigger breasts, wider hips, and so on and so forth. So as women get into the menopause, the ovaries start reducing the amount of estrogen that they produce, and because the fibroids are estrogen dependent, they will start reducing in size and they will shrink to a minimal size. Is there a certain age when there is a prevalence? Yes, and that is during the reproductive period. I haven't seen a pediatric patient, and these are 13, 14, 15 or even less children who have fibroids. So that again comes to when the ovaries kick in and start producing estrogen. That is the age prevalence. Remember, I talked about the reproductive period. Now, what was the other way? Lifestyle.
Yes.
Lifestyle, we actually don't have a lot of information. However, it is possible that some of the foods that we eat, here I'm just saying, some of the foods that we eat could be a reason, but then if that were to be the reason, then logically thinking, do we eat the same foods in the whole of Africa? We don't. What about those women of African origin in other parts of the world? They may not eat the same types of foods. Could it be genetic? Not necessarily, because if we are talking about genetics, it means that, for example, there is sickle cell anemia in the family, meaning that it doesn't matter. If my parents are sicklers, there is a chance that there is 25% chance one of my siblings will be a sickler. There will be 2 who are carriers and 1 will be okay. So it doesn't matter where you go, it will be the same. But it's not the same for fibroids. However, there is a casualty. What do you call casualty? We say, my mother had fibroids and I have fibroids. So it is, quote unquote, in the family, but we don't have a genetic cause-link effect
to that,
as it were.
Causation is not correlation is not causation.
Correlation is not causation.
Yeah.
Is there a certain type of size of fibroids that affects impact of fertility?
Oh, yes.
That impacts fertility. And then we'll also talk about IVF. Tomorrow is actually
World IVF
Day, as we talk about fertility. But yeah, are there certain sizes that impact fertility more than others?
Actually, yes, especially the fibroids which are in the cavity, the ones I mentioned in the beginning, called submucosal fibroids. We are created in, as the psalmist says, we are wonderfully and beautifully made. I think Psalms 139. We come from cells which are invisible. You can't see an egg with your naked eye. You also can't see sperm. But when they meet and under a microscope, under high magnification, is when you see the tiny, tiny cells where all of us come from. Now, normally, maybe just quickly about how this happens. During ovulation, when there is intercourse, the man releases his sperm around the cervix, and these sperms swim and through the fallopian tubes, and they get to the egg. Fertilization occurs. When fertilization occurs, this embryo, because that's the beginning of a baby, has to travel back all the way to the womb, where it drills a small hole on the lining of the womb, and it attaches, and the baby starts growing. Now, if there is a submucosal fibroid, even if it is 0.5 centimeter or 1 centimeter, maybe there is one, maybe there are several in the cavity. Remember, this is a microscopic structure, and it has to find where to stick. So that 0.5 centimeter for this microscopic structure, the embryo, that 0.5 centimeter is like Mount Kenya for it. It may not be able to circumvent that, that size in order for it to be able to get to where it is. That is number one. Number two, there are fibroids which, like I mentioned, which are dangling, pedunculated. So if it dangles from the cavity all the way to the cervix, it can block the cervix, and sperm may not be able to swim to get into the cervix to get where it's supposed to get. If they're big fibroids, they can overstretch the uterus, and they can block the tubes. If the tubes are blocked, sperm may not be able to swim through and get to the eggs. You see, when a woman ovulates, the body knows, even the sperm know that we are going to the left this time, not to the right. Why? Because there is a mechanism whereby the uterus contracts in such a way that it sends the sperm to the right direction. So if there is a fibroid there, the sperm, the uterus may not be able to contract in the right way to send the sperm where they are supposed to go. So they may end up either hanging around in the womb and nothing happens, or even going in the wrong direction, as it were. The submucosal fibroids can also produce some substances, some chemical substances, which can either stop the sperms from swimming, or they can also create an atmosphere which is not conducive for the embryos to actually implant, and all this leading to infertility. Now, if the fibroids are big and the woman gets pregnant, what happens is that a lot of blood starts flowing into the womb to feed the baby with nutrition, oxygen, and so on. The fibroids will also take advantage of that amount of blood which is flowing through it, and they will start also growing with it. If there are several of them, the womb will reach a stage where it starts contracting, not because the pregnancy is term, but because a signal has been sent to the brain telling it, you know what, send a hormone called oxytocin, because this size, when a womb gets to this size, it means that whatever is there has to come out. So this leads now to the premature deliveries, and even sometimes to miscarriages. So this does contribute to infertility. We've had patients who've had fibroids before, and we did IVF and it didn't work, and when we removed the fibroids, everything worked out well, and so on. So yes,
there's a link.
They do contribute significantly to infertility.
Because of time, I'm really thinking through it. Can we do a part 2 on breastfeeding, and then for the next about 15 minutes or so go into fertility issues, so that then we can have you again for breastfeeding and exclusively. There was a very interesting report on how many how many moms are breastfeeding now.
The numbers are dropping.
The numbers are dropping.
I hear Mariam's point, because it's literally like 10-12 minutes.
Right.
And you're right, we can do a deep dive, because this is also very critical.
Very, very critical, yes.
But now let's switch to fertility. First of all, are our fertility numbers dropping? I know the number of births per woman is dropping globally. Same is for Kenya. But do we have increased infertility issues, or it's just a factor of course, the longer you spend in school, the access to reproductive health care, and all of that?
When we talk about infertility, the definition of infertility is a couple, heterosexual couple who are in a relationship. And in this relationship, it doesn't matter what type of relationship it is, they have intercourse 2 to 3 times a week, and a year has passed and there is no baby with a small caveat that the lady is not 35 years or above. If the lady is 35 years or more, then that time period of 1 year is shortened to 6 months.
Okay.
When you talk about, that is what is called primary infertility. Then we have secondary infertility, whereby this couple have had a baby or they've had a conception in the past, and they are trying to have another conception, and the other criteria still apply. 2 to 3 times of intercourse a week, and a year has passed, and the woman is not breastfeeding. We'll talk about breastfeeding later on.
Right.
Yeah. Now, when you talk about our fertility rates increasing and so on, unfortunately, we don't have a register. What other countries have, especially in Scandinavia. Scandinavia, for the last, I don't know, 50, 60, 100 years, they document everything about their people, when they were born, where they were born, etc., etc.
Yeah.
So it is a lot easier to go back and say, look, we have looked at our registers and this is where we were at a certain time, this is where we are, what is happening? We don't have that. We have very sporadic data. Research which has been done shows that in Kenya, or generally in sub-Saharan Africa, our infertility rates are quite high, ranging from anywhere between 10% to even up to 30% of the population who are in that reproductive period. Now, it is paradoxical because, again, sub-Saharan Africa has the highest fertility rates as well. So we have the highest fertility rates. We also have the highest infertility rates.
Okay.
And this is because of several factors. People say that the lack of other things, then sex is one of the things that people do. There is no TV in the villages and so on. So they do other, what they call badminton, as they say, and so on.
Badminton.
Now, badminton better. So we have a challenge with that. Now, when you talk about causes of infertility, these causes are both ways. They can be female, they can be male factors. Sometimes it is both. Sometimes it is quote-unquote unknown. When it comes to some of the factors without any hierarchy, for example, we talked about age. You mentioned, is it because people are spending more time in school and so on? That is also a factor. Because remember, our grandmothers used to get married at around 14, 15. As soon as they have their periods and the breasts have started appearing, you are wife material. And they will start bearing children. They'd bear 10, 12, you know. And now it is not feasible for a lady to go to school and then still, you know, deliver 10. 11 children, as it were. So age is a factor. And I talk to our medical students when we are talking about infertility. And when we work out, we find out that by the time a medical doctor finishes the education, the formal education, and starts working, they're about 33, 34 years. That is when they come out as specialists. And they still need to work for maybe 2 years before now they get an independent practicing license. So they're about 35, 36 years. So if for ladies, if they didn't get a husband or they didn't have a child during that training, it's going to be a challenge because they've got into that age whereby the number of eggs has reduced after 35. Fertility drops in women because of the number of eggs which are there, and the quality of the eggs becomes poorer. So if it is a normal aging process. So if the quality of the eggs is poorer, the embryos that we'll create will not be good, and implantation will be poorer. Or if they do implant, they will end up in miscarriages more. So, and this continues with age.
I wanted to ask that. Looking at recent, I don't know, obstetrical, gynecological trends, a lot of women are having children older, especially in the West. Is there a sensationalism to this idea that post 35 fertility does drop throughout time, yes, but was there a sensationalism, a kind of fear-mongering as to how sharply fertility declines after 35 or even 30?
Like, where is the line between the sensationalism and the truth?
And the truth,
and the fact,
It is actually no sensationalism. It is facts. And facts, unfortunately, somebody said you can't hide facts. The facts are stubborn and they're there. How do we get to this 35? Or when we get to 35, how do we actually determine determine that fertility is still there or fertility is reducing? By doing some tests. We do a blood test to check what you call a hormone called anti-Mullerian, depending on which school you went to, anti-Mullerian hormone. And this hormone tells us about the ovarian reserve. You know, when we take that blood, the machine doesn't know who it belongs to. So it's not subjective, it's very objective. So if that level has fallen, vis-a-vis a lady who is, let's say, 24, 25, and you can actually see the trend. And when you do studies, you actually see the trend from the 20s, early 20s, mid 20s, and whatever. The AMH is very high, and then after that, when it gets to around 30, it starts dropping. At 35, it's a sharp drop. So it is something which is objective. The other thing that we do, because we need to look at the AMH together with the scan results, transvaginal scans, we also see a drop in the number, what we call antrofollicle count. What are follicles? Follicles are basically the casing or the housing of eggs. So if we see that the antrofollicle count is around, let's say, 10 or less than 10, vis-a-vis a younger women where the antrofollicle count could be 15, 20 or even more, and we look at trends, it also gives us the same information. So it's not sensationalism, it is fact and it is biology. In as much as we say that age is a number, yes, it can be a number, but we cannot cheat biology.
Right, but let's maybe speak to options, and maybe this is where IVF or freezing of eggs comes in. Absolutely. July 25th, which is tomorrow, the first, Dr. Ari is here, he can confirm, but it was the birth of Louise Joy Brown, who was the world's first IVF baby. And this was in 1978.
1978.
Look at that. July. So it was obviously a milestone in medical science. So let's talk about that, because I think
this child is about to turn 50.
Yes.
The first child of IVF is about to turn 50.
Still young.
It's 47.
It's still young, right? Seems like something. I think when I heard Mariam asking that question, it's because now what's happened is, in as much as there's science, there's also reality.
Correct.
There's support structures. There's so many factors that makes a lot of women say, I want to make this decision when I'm certain.
Yes.
When they're certain. So let's talk about then two things, actually. One is that thing for if you haven't had a child by your 30s or 40s, you are more likely to develop fibroids. I don't know if that's myth or fact.
It's
like an empty womb. What was that called?
Yes.
A womb that isn't producing a baby is a womb that's inviting fibroids.
Not necessarily.
Not necessarily. And then now let's talk a little bit about IVF. What is it? What are the options people have? And if we have time, speak to freezing of eggs. Just as, you know, and as far as I don't want to do this now. I know my age is ticking. But what are my options? So maybe the myth versus fact. Fibroids.
Fantastic. The first IVF baby in 1978, brought a lot of confusion in the medical and also in the religious world, because the religious fathers were saying, hey, now we are acting God. We are creating babies in the lab. But it was an option which has opened, which has given opportunity to millions of couples around the world and thousands of them in Kenya as well. When we talk about IVF, generally, fertilization takes place in the tube. I mentioned that a little bit earlier on. But now, if there is a problem with the tubes, for example, the tubes are blocked, the tubes have fluid in them, or the tubes are not there, they've been removed because of diseases, for example, or there have been ectopic pregnancies and we have to remove the tubes. So this woman may not be able or will not be able to get pregnant naturally. So this is where IVF comes in, because in IVF we don't need the tubes. There is also male factor problem, because if the sperms are not swimming the way they should, the numbers are also not there, the quality of the sperms is also not there. So IVF is an option, and it actually is one of the best options. When you talk about IVF, it's basically this is generic. When you talk about IVF, we take eggs and so on, and we create that baby in the lab. IVF in itself basically means that we prepare a patient who has this problem. We have diagnosed there is a problem either with her or with the husband or both of them, and we put her on a treatment regime. We inject her with injections every day for about 10 to 14 days. When she is ready, we want her to come. We take her to theater. We collect the eggs. There is no cutting anywhere. We collect the eggs through the vagina. Once we have collected the eggs, the husband gives us a sperm sample. We clean it, because not all the sperms that are available are okay. Once we've cleaned it, we can do two things. We can take the sperm and a droplet of the sperm, which has millions of these sperms, and put together with an egg without any intervention. That is the IVF now, in vitro fertilization. Or we can take the egg and we take the sperm and literally inject the sperm into the egg. It is still called IVF, but we know it is called ICSI, I-C-S-I, intracystoplasmic sperm injection. So essentially what we are doing, we are helping these sperms, which were not swimming fast enough, for example, so we are pushing them into the egg. Once we have done that, we put this in an incubator, because remember, our bodies have a certain temperature. All these processes that happen naturally happen under a certain temperature. So we want to mimic what happens in the female body, put them in an incubator, they start growing, and we'll be monitoring how they grow. And once they're ready, after 3 to 5 days, we take the embryos and we transfer them into the patient. Now, the options that you asked about because of age, these options are there. We can freeze the eggs. If this lady feels, you know what, I haven't found Mr. Right yet, and I don't want to get Mr. Left and pull him to the right. Let me just freeze my eggs. So it is possible. She also goes through the same process of injections. We get to the eggs and we freeze them for her. How long can we freeze them? 5 years, 10 years. In the UK, there was an embryos which were frozen for 20, 21 years, and they were actually thawed, and babies came out of it. So they were actually talking about legalizing the freezing of embryos, or gametes for that matter, for 50 years. So it is not a problem. We can freeze these embryos. And the other thing is that at Frontline Medical Consultants, we actually do all this. We do the freezing of eggs, we do the stimulation, collection of eggs, and we freeze everything. When you say everything, it will mean everything. We freeze sperms, we freeze eggs, we freeze embryos, and so on. The only thing that we are not able to do yet in Kenya is the freezing of pieces of the ovaries in patients who have ovarian disease, ovarian cancer, for example. Because if they are caught early, we can actually, in other places in Europe, they do that. They remove pieces of this of the ovary and freeze it. And once the patient goes through treatment, they can be brought back and sutured onto the ovary, stimulated, and then baby can be born out of it. That and uterine transplants. Those are the two things we are not able to do in this country. But otherwise, anything and everything else, what is done in the US, Germany, South Africa, India, we're able to do it locally.
The cost is high. We had time, like a joke. Even somebody here is saying, bring back the good doc, guys, GBM. Kikombe is saying the science is sciencing.
It is. He also was marveling at this interplay between nature and science. It's really beautiful to watch.
We really need this. Mariam was right. Like we can't even touch on breastfeeding right now.
Not yet.
But this is such an important conversation. We haven't even gotten to the cost, because you've said everything is available in Kenya.
Yes.
But at what cost? Should we try a minute?
Yes.
60 seconds.
60
seconds.
seconds.
If you can.
It's time, we are counting down. Now, the cost is actually, sometimes it can be prohibitive, because it's anywhere between 400 to 700,000 shillings. Now, that is a huge cost. We are calling on the government, because most of the patients are actually, infertility affects all strata of society. And if it were possible for SHA to actually, even if it were to help, cover, subsidize the treatment, it would increase, number one, the equity, accessibility and availability of these services to all women in Kenya, not only the ones in Nairobi, the ones in Moyale, Mandera, Wajir, Migori, Isiolo, whichever part of this country. Then we can go back to Article 43 of the Constitution and say that we're actually providing quality care and highest quality of care, and even in reproductive health. So I think SHA can and should help these patients.
And that's it. We are at time. Dr. Kireki Omanwa is the president of the Kenya Obstetrical and Gynaecological Society.
Yes.
Thank you so much. I think this definitely needs a lot more time. There's a lot of people who are depending on it to make plans for themselves, to explain to their families, etc. But thank you so much, and for the work that you do. Coming out at 8 a.m., we have Anthony Njaramba, the CEO of the Water and Sanitation Providers Association, talking about how we can make water access achievable, universal water access achievable. It's coming up to 8 a.m. This is Fixing the Nation, one conversation at a time. We're back in just a moment.